Welcome back to day 2 of the Cake and Pie Expo, where we're about to get cracking in terms of rolling out updates in Retina. Now, this session is moderated by Dr. Ken Fong out of Malaysia. The first topic is the beauty and usefulness of imaging with intraoperative OCT by Dr. Barbara Parolini from Italy. Second up, diabetic macular edema management in an Asian population by Dr. Augustinus Laude. And finally, updates on AI for retinal diseases by Dr. Paisan Ruamviboonsuk. Thanks so much for joining us here at day 2. Let's get cracking.
I am Dr. Barbara Parolini, and I will talk to you about the beauty and usefulness of imaging with intraoperative OCT. We will focus on perfection. I will show you when OCT guided me and I followed. These are the topics we will touch: peeling, high myopia, subretinal surgery, retinal detachment, and situation with no preoperative view. Let's start by saying when OCT is a guidance in peeling membranes. Why peeling need OCT guidance at all? Well, the retina is transparent and the membranes are transparent too, so how to distinguish one from the other? We can easily distinguish the retina from the choroid because the choroid is colored, but membranes are transparent, and here I am finding the plane of separation, but not all the cases are so straightforward as this one. And certainly staining is one solution, and here the Proveo 8 microscope is showing a separation of the membrane, which is stained with blue, and the view is marvelous, and I can easily see every step that I am doing, but this is not a solution in every case. For instance, how to see when there is no contrast, on how to verify the position of an ILM flap under air, how to verify the reaction of the retina in difficult situation at risk of iatrogenic lesion. Look at this case. On the left, the microscope view shows a very little because there is no contrast due to atrophy and microretinal hemorrhage, microhemorrhage. So on the right, we see that the intraoperative OCT can tell us easily where there is the ILM flap and where there is a hole. So here under air, at the very end of the case, I am staining again, but reflexes and atrophy prevent the good view. And so if you find, like in this moment, with all the reflexes, you don't see exactly what you're doing through the microscope, while the intraoperative OCT tells you what to do because the ILM flap is in the hole. And this seems a similar situation of peeling, but indeed they are very different. The one on the right is in this type of fundus, while the one on the left is in this type of fundus. They are very different cases. This is a 50-year-old male with a severe myopia and extreme atrophy. He was operated by me for retinal detachment, and 1 year later he developed this bad gliosis. He was desperate. I've been waiting because I didn't want to operate, but then vision went down and down, and I had to remove that gliosis. So while I was peeling, I was asking myself, am I detaching the macula? Am I creating a hole? Am I peeling too much? Am I peeling at all? And looking through the microscope, I was not sure about the answers. I had many moments of uncertainties because I did not have all the information that I needed through the microscope. While through the intraoperative OCT, I had an immediate answer. I could see that in this moment I was just caressing the gliosis, but I was not efficient in removing it. While then I started to peel and I could remove the epiretinal proliferation, unfolding the retinal folds. And so I knew what I was doing, and I also knew that I was not inducing a macular hole. So this is new concept for intraoperative OCT. The microscope shows the movement, while the OCT shows the effect of the movement. It shows the shadow of forceps, the edge of peeled epiretinal membrane, the retinal folds which are unfolding. Again, you see on the left the forceps performing certain movement, while on the right you don't see your hand, you don't see the instrument, you see the effect of your movement on the tissue. You see the epiretinal tissue, you see the folds of the retina which are unfolding. And this is the pre and post-op of that specific case. So what about high myopia surgery, and what role has the intraoperative OCT in this type of surgery? So this is a new staging system of myopic traction maculopathy that I recently published. And so the whole variety of MTM types are summarized in one single table that shows the evolution from inner schisis to macular detachment from stage 1 to 3 to 4, and on the horizontal evolution you see in the columns normal fovea evolution to lamellar hole to full thickness macular hole. MTM can evolve from top to bottom, from left to right, and in oblique. And focus is useful both in vitrectomy and in macular buckle in high myopia. In vitrectomy, again, to see when there is no contrast. Look, the comparison between left and right through the microscope, we barely see where the macular hole is, while on the right, we know exactly what we are doing at the ILM, which is large enough and is exactly on the hole. And this is another example. If you compare the two images, you see that on the right, you have a great help. With buckle, OCT is useful to see the location of the buckle and the pushing effect, the buckling effect. You also see the hole over the buckle. In this case, look at the intraoperative OCT view. It is very informative and you know exactly what you are doing while inserting the macular buckle. And again, here you see that the hole is closed and is on top of the macular buckle, while on the left you could have many uncertainties on what you're looking, especially through air. This is an extreme case. I am implanting a macular buckle only with the guidance of intraoperative OCT without endoillumination at all. This is only buckle with no vitrectomy. So you see my coworker pointing at the location of the buckle, which is exactly under the fovea, and you see the images live through the intraoperative OCT. So what about cases without preoperative view, cases where media opacity prevents performing the OCT preoperatively? So you go to surgery, but you don't know the status of the fovea. Well, you remove with surgery the opacity, in this case dense vitreous hemorrhage. So you can perform the OCT during surgery and you know whether you have to perform maneuvers on the fovea or not, like in this case. What about retinal detachment surgery? Well, besides looking if there is PFCL left under the fovea, you can decide whether to peel or not to peel the ILM. In this case, the thickness of the fovea was so little that I decided not to touch the ILM in order to prevent a iatrogenic macular hole. While in a case like this, the fovea looked thick enough, I could see folds, radial folds, so I decided to move on and peel the ILM. And on the right, I see the effect of my movement. But surprisingly enough, you see that the folds are still there after the peeling. Why? Look at through the microscope. Well, the OCT could tell me that there were microfolds on the choroid, but not in the retina. So my case was done. It was very informative. And you can also differentiate schisis and detachment. Look at this difficult case of retinal detachment associated with the X-linked retinoschisis. The first surgery was vitrectomy, buccal, removal of the inner layer of the retina, and siliconoid. And this is the intraoperative view of the second surgery for a relapse of detachment. There are many uncertain findings. I was wondering whether A was a hole, B was PVR or retinal folds or subretinal strands, C, subretinal PFCL bubbles. The focus was a guidance to understand that actually A, yes, was a hole closest to a cyst. The B were areas of inner schisis and remnants of the inner retinal layer that I had trimmed in the previous surgery, and C were areas of schisis and not PFCL bubbles, so I did not have to go under and remove them. What about PVR? Can the OCT be a guidance here too? So this is a very bad case of PVR, but I think that this is worse. This patient comes for second opinions, but he already had 5 surgeries for retinal detachment. And I could detect a subtle retinal detachment in the inferior quadrants, but this patient is worse than the full PVR because he has higher expectation and he's tired of surgery. You cannot make mistakes. So I think OCT can help locating immature PVR, and also it helps in the judgment of residual traction. This is a pathognomonic sign of intraoperative intraretinal PVR. This is another example. If you go there, you know that you have to peel. And in fact, you see here that specific spot. I am removing. First, I am searching for immature PVR, and with the scraper and the forceps, I am indeed removing some epiretinal tissues so the retina can relax and open. But you can also judge residual traction. I think this is one of the greatest challenges in VR surgery, how to judge residual traction. Can the intraoperative OCT finally be a traction meter or a traction detector? In cases like this, you can wonder, should the retinotomy be lifted again? Should the membrane by the retinotomy be peeled or left over there? Is there residual traction? It's not easy to judge. So look at there. The intraoperative OCT shows that the edges of the retinotomy are contracted and there are epiretinal membranes. So you move on, peel the membrane, elevate the retinotomy, and then reattach the retina. And then if you compare prior and after your maneuver, you see the difference. So after your maneuver, the edges are more relaxed and there is no residual traction. Like here, the edges are now relaxed and there are no epiretinal tissues membrane left to be removed. So the case is finished. And this is the post-op view. So in summary, I think that the advantages of the intraoperative OCT are confirmation of what we see with the microscope and the ability to see what we do not see with the microscope. And the surgeon gain precision, speed, knowledge, researchability, and training efficacy. So one step closer to perfection because to be able to see is to be able to do. Thank you.
Thank you, Dr. Parolini. My name is Dr. Kenneth Fong, and I'll be the moderator for this session. And with me today live is Dr. Gus Laude from Singapore and Dr. Paisan Ruamviboonsuk from Bangkok. So before we go on to the next talk, we have a question from the audience and from New Delhi. Dr. Arun Sethi is asking, if in the cases of lenticular haze or opacity, would you recommend one-time lensectomy with retinal surgery or in 2 steps? So maybe Gus, you want to share what you think about that?
Well, firstly, disclaimer, I don't do retinal surgery. I'm medical retina.
Okay.
But I think in consultation with my colleagues, I think majority of the cases that I do have, they will manage it all in one sitting.
Yeah, I agree. Yeah, I think it's much more convenient to do a phaco and then combine it with vitrectomy. And I would do that very commonly because during the operation itself, if you put gas or proceed, the cataract may progress and impede your view, and then it'll be very difficult to have to stop halfway and do the cataract removal. So if there's a cataract already at the beginning, I would just do the phaco first and then do the vitrectomy. Paisan, what are your thoughts on a combined operation?
Yeah, I agree with you. But the thing is, well, the cons for the combined procedure may be a longer procedure time. That's about it. And
Okay.
well, if you do phaco at the same time, you may have to be careful post-operatively because you have multiple wounds there. Yeah, a little bit of precautions of combined surgery, but you can do it almost all cases.
Yeah, I think for me, the most important is to make sure the pupil is well dilated post-op, because it's very common to get posterior synecdoche on the IOL to the iris, especially you put a gas bubble in the eye. And then if you get pupil, you can get pupil-blocked glaucoma if the pupil is not dilated. So I always put a drop of atropine at the end of a combined operation to make sure the pupil is nicely dilated for at least 2 weeks. And they have to use the steroid post-operative drops very conscientiously to prevent excessive inflammation. So we'll go on now to Dr. Gus Laude from Tan Tock Seng Hospital in Singapore. And Gus is going to talk to us about the latest in diabetic macular edema management in Asia. So Gus, over to you.
Thank you very much, Ken. Good afternoon, ladies and gentlemen, and to our friends on the internet world. I'd like to talk a little about this management of diabetic macular edema in Asian population. So the title of my talk is probably the most unimaginative and boring amongst all. Nothing very exciting in terms of cutting edge technology we saw earlier. And there's no special buzzwords like AI in my next presenter that's coming on after me. So I'd like to start by declaring some financial disclosure that this particular study which I'm presenting was funded by Allergan, for which I received some travel and funding support. And in the talk will include a discussion about the use of Ozurdex, which is a product from Allergan. So what is the motivation behind this was to gather a group of vitreoretina doctors together, lock us up in a room. There are actually 12 of us. We come from various countries in Southeast Asia, India, Malaysia, Philippines, Vietnam, Singapore, and with the purpose of trying to discuss about the role of intravitreal treatment for diabetic macular edema. Specifically, we wanted to discuss the use of intravitreal steroids, namely Ozurdex or dexamethasone implant, in this group of patients, because we feel that there is some paucity of information in the literature. And so we would like to do the literature review and try to come together to reach some sort of a consensus. So this is really opinions of a group of retina practitioners who are very youthful and very cordial with each other. There were no fights throughout the course of the consensus building. We did use a known method of the Delphi questionnaire to pass through 2 rounds using questionnaires initially filled with anonymously and in one meeting, and then we come together later on after the questionnaire results have been scored. And consensus is defined if more than 75% reach agreement. And out of the 49 questions that we set out to draw consensus, we managed to achieve 25 out of 49. So as I said, it's not unlike the show 12 Angry Men for those who have seen it. We're all locked up together in a more comfortable environment, and we went through all these questions. This is a summary. Oh, I mentioned earlier on, sorry, that this paper has been published in APJO. It's open access, so please feel free to download the paper for your reading pleasure, because there's no charge for it. So this is a summary of our findings, which it's available in the paper, and I shall not go through the details, but it provides a kind of bird's eye view of the kind of treatment algorithm for your reference in your day-to-day clinical practice. However, for this talk, I would like to share with you some of the highlights or shine some spotlights of the findings that we achieved. We do know that the use of intravitreal steroids in the management of diabetic macular edema, we do know it works, but it's not without its issues and problems. So we would like to spotlight or shine a spotlight on the management with the 2 major shortcomings of intravitreal steroids, namely intraocular pressure management or glaucoma, how to handle patients with cataract and the cataract formation, and also to try to discuss what are the considerations in the management of using this intravitreal dexamethasone. So for glaucoma or intraocular pressure management, these are kind of the groups of scenarios that we think that a typical practitioner will come across. Variations in the level of intraocular pressure that the patient has at presentation, whether or not this raised intraocular pressure is associated with any optic nerve damage or glaucoma, and the various kind of approaches we take. Suffice to say that we don't believe that raised pressure or glaucoma is a definite hard contraindications to the use of intravitreal steroids, including dexamethasone. However, we all agree that intraocular pressure needs to be actively managed during the before, during, and after the use of intravitreal dexamethasone. So we also believe that patients must continue to use their anti-glaucomatous medications, and they need to be monitored very closely with repeated checks of the pressures. And if the pressures are showing signs of elevation, that needs to be managed aggressively. And it's also good to involve your glaucoma colleagues in the management early on, so that in case we need more aggressive or additional treatments beyond that of topical anti-glaucomatous medications. How about for cataracts? We do understand that patients who are receiving intravitreal dexamethasone should be informed and counseled about the cataract formation, which typically will become evident about 1 to 2 years following the treatment. For those patients who do have pre-existing cataracts, we do know that the intravitreal dexamethasone use do make the cataract progress more quicker. However, the group also feels that those who require cataract surgery, use of adjunctive or combined with intravitreal dexamethasone following the cataract surgery is actually a very good option, and also helps manage the recovery from the surgery quicker, and also minimize or reduce the risk of postoperative worsening of the macular edema in diabetic patients. Overall, the group also feels that in the management of diabetic macular edema patients, when we do consider the use of intravitreal dexamethasone, we do pay attention to the various para conditions. This is a personalized treatment, and so for each individual, when we are considering intravitreal dexamethasone, we feel that it's very important to try to understand what is the perfusion status of the patient, whether or not there's any issues with vitreomacular interface. We do want to know what is the location and the distribution of the edema relative to the fovea. And we do want to know the clinical cause of the disease and the distribution of the edema, because we feel that these factors do have important prognostic factors in terms of the treatment outcomes. There were some issues that we couldn't reach consensus, for example, whether or not to perform a fluorescent angiography for all diabetic macular edema patients prior to the intravitreal dexamethasone treatment, because some practitioners do believe that you need it, but there are some that do not feel that it is necessary. And in considering the role of anti-VEGF versus intravitreal steroids, as we all agree that anti-VEGF has a very important role in the management of diabetic macular edema. Nevertheless, we do recognize that there will be a proportion of our patients who will not respond well to anti-VEGF treatment. And in this group of patients, we feel that there is an important role of using intravitreal dexamethasone. And also, not only that, for anti-VEGF use, the studies have shown that you need a very intense, repeated injections, and also intense and very close monitoring of the patients in order to replicate the excellent results, outcomes that has been shown in the clinical studies. In actual clinical practice, in the real world, sadly, those kind of regimes cannot be replicated. And this often leads to poorer clinical outcomes that we often see in our day-to-day clinical practice. So in patients who are poor responders to anti-VEGF treatment, there's also evidence that switching to intravitreal dexamethasone may have a better outcome compared to switching to another class of anti-VEGF agent. Another factor to consider in the treatment was to explore the use of various inflammatory biomarkers in the DME, whether it's biomarkers in the blood or aqueous or imaging biomarkers. But the panel feels that at the moment, there is currently not enough evidence to guide our treatment planning. So we hope that in the near future, there could be more data and more work coming out in this area to help guide our treatment decisions and retreatment decisions. We do explore and we do appreciate that there will be a number of patients that will present with heart exudates, very dense heart exudates around the fovea area, which is associated with poor visual outcomes. And we found evidence that the use of anti-VEGF and intravitreal steroids can be of benefit, but there is some evidence to show that using dexamethasone in these specific cases with high density of hard exudates may achieve better visual outcomes compared to intravitreal anti-VEGF. Also, another big area of contention were patients who had previous vitrectomy for various reasons. And the question was, what is the, is there any concern about the efficacy using intravitreal dexamethasone? And there's data to show that actually, whether or not the eye is vitrectomized, the intravitreal dexamethasone has been shown to give very good outcomes. So it doesn't seem to be affected too badly whether or not the patient has had previous vitrectomy. There was another interesting discussion about when we put the intravitreal dexamethasone implant, where the location of the implant relative to the anterior segment seems to be important, and there's data to show that the closer the dexamethasone implant is to the ciliary body and the pars plana region, the higher association with raised intraocular pressure, or there is a higher necessity for multiple anti-glaucomatous drug to control raised intraocular pressures. So this was interesting observation in the data. So I'd like to do a conclusion. Now, this is a conclusion from the paper in general rather than from this talk, but we do want to share in our paper that there's adequate evidence at present to support the use of intravitreal dexamethasone in diabetic macular edema, in particular for patients with pseudophakia or in patients who we anticipate to have poor compliance with follow-up, and also patients who had been previously vitrectomized or who had undergone cataract surgery. So they are pseudophakic eyes. These are particularly worth considering intravitreal dexamethasone. We also established these guidelines, and we hope that it will be useful in helping clinicians identify the various types of responders who may respond to this particular treatment modality, and also help determine when they are considering switching in the event that the patients do not respond so well to anti-VEGF treatment. We also try to give some of the clinical parameters or patient factors for consideration of likely to respond to intravitreal dexamethasone. And also, we hope to provide some data and guidelines in terms of management of the two big complications that are associated with the use of intravitreal steroids, namely management of intraocular pressure, raised intraocular pressure, and cataracts. So with that, I'd like to thank you for your attention.
Thank you, Gus. That's a very interesting talk, and thank you for summarizing the Asia Pacific guidelines to us. I'd like to welcome Dr. Barbara Parolini, who's joined us from Brescia, Italy, and we have some questions for you. Dr. Parolini, can you switch on your microphone?
Hi.
Hello.
Hello.
Yes,
How
thank
are
you
you?
for joining. Yes, we are well, thank you.
Thank you.
We really enjoyed your talk about intraoperative OCT, and this technology has been around for a few years now, and it's nice to see you using the Leica system. I've just got two questions for you. Firstly, have you used the Zeiss system, and how does it compare with the new Leica system? And secondly, is the cost of an intraoperative OCT justified in a day-to-day vitreoretinal practice? Because I mean, in real terms, it's almost buying another microscope if we were to upgrade our current microscopes with the intraoperative OCT option. Thank you.
Thank you for your question. And yes, I have been using both systems since the beginning. I could compare them in a different microscope as well. I think the main difference is that now with the Leica system, you have more freedom. The operator, the surgeon, has more freedom to use it with the foot pedal And the scans are long, different shape, different sizes. You can play a lot. By using it every day, it becomes like, now I don't want to use a microscope without intraoperative OCT, because when you start using it, as with any new technology, you find the benefit and you want to have it. I totally agree with the fact that the price is not competitive, and it will go down, as it always happens with the new technology. It's like with the 3D system, most of us don't buy it because it's not justified. But even comparing the two technology, I must admit that the intraoperative OCT, I find it much more useful than the 3D system. If I had to choose, if I could have all the money in the world and I could choose the two systems, because it really can change the strategy of your surgery. It improves your surgery. You have the confirmation of what you do. I have tried, as you have seen, in many different situations, and it's great to have. I think our surgery improves. So I think the money is worth, even on a daily basis. And then, of course, anyone can make their own consideration, but I think it's worth.
How long is the learning curve to learn? Because with the Zeiss system, there was an overlay in one of the eyepieces, and I found it quite distracting. How does the Leica system? How do you? Because do you have to look away from your microscope eyepiece to look at the screen for the OCT, or is it inside the eyepiece itself?
It's not inside. They are changing the system into a system incorporated into the microscope. It will be available this summer, but I think having it in the eyepiece is distracting. I have tried with the other system. I prefer to do my maneuver, just stop and switch on the monitor, which is dedicated, and I have the live view of the microscope and the OCT. And I can mildly move the eye and change my scan, the right location of the scan, and check what I am doing. You can do it like almost live. It's true, you have to stop, watch, and then start back. But then you seem to waste time, but you're not wasting time, because since you know what you have to do, then actually you're gaining time. So I prefer this way. The learning curve used to be very tough because the system was complex, but now it's getting more and more user-friendly. So I would say that like in 3-4 sessions of full surgery, you're ready to go, and the training curve is done.
Sure, thank you. So we are a bit running short of time. So I'd like to introduce our final speaker, Dr. Paisan Ruamviboonsuk from Bangkok, Thailand. And he's going to share with us a very interesting topic, which is AI, updates on AI and retinal disease. So Paisan, please go ahead.
Thank you, Ken. Well, it's my pleasure to join this symposium. Here's my financial disclosure. Well, here are some common tests for AI in medicine. The first one is to perform classification, which is automated detection of disease or no disease, or detecting refer or non-referral. The second one is segmentation. Segmentation is kind of automated identification or localization of the boundary or areas or volumes of biomarker of disease. The third one is to do prediction, which is a kind of like automated estimation of clinical cause of disease in the future. Here's aims of AI in common retinal disease. In primary care setting, we like AI to perform screening for diabetic retinopathy or AMD in population at risk. Just for example, in tertiary care setting, you may use AI as an assessing tool for DME or wet AMD detection, monitoring, or decision making in clinics and in research. Well, you have many kinds of retinal images for analysis, like color fundus photos, or CT or CTA angiograms. Well, here's a breakthrough paper published in JAMA in December 2016. Well, as of early this month, this paper has a view of more than 280,000 already, and there'll be like more than 3,000 citations already. In this paper, they used deep learning algorithm to detect referable diabetic retinopathy from color retinal images. Why is breakthrough? Because the AUC of this paper found to be like more than 99% in 2 of the external validation sets. However, this is a kind of like retrospective study. Nowadays, we found more papers on prospective real-world screening of diabetic retinopathy, just like this paper from the UK. Well, in this paper, they performed prospective screening of more than 30,000 patients on more than 30,000 consecutive screening episodes from the 3 UK DR screening sites. Patients in these screening sites were manually graded from human graders, as well as the AI, which is commercially available. It's called iArt. Well, here's the result. Well, sensitivity from the real world screening using AI was found to be 95.7% for referable retinopathy, which means ungradable images and referable maculopathy and moderate to severe NPDR or PDR. Well, this kind of sensitivity comprises of sensitivities of 98.3% for mild to moderate NPDR with referable maculopathy, and 100% for moderate to severe NPDR and 100% for PDR. You found sensitivity this high, the specificity is quite lower. Well, it's found to be like 68% for no retinopathy and 54% when combined with non-referable retinopathy. We have more paper for prediction of DR progression today. Here's a paper. They try to predict the risk of developing of new cases of diabetic retinopathy using deep learning. In this paper, they have 2 versions of deep learning. The first version is to perform prediction on 3 fields of coronal images, and the second version is perform prediction on a single field in a primary care setting with a development data set of more than 570,000 eyes and more than 28,000 eyes with known outcome, and the remaining more than 540,000 eyes were used for augmentation of training. The validation in this study was performed in 1 eye, selected randomly per patient from 2 data sets. The internal validation was performed using the iPad and the tele-retinal screening in the US for more than 3,000 eyes. And external validation, they use data from Thailand dataset, which have more than 2,000 eyes. You can see that, well, for internal validation, if you use like 3 field deep learning, the AUC was 0.8, which is pretty good. For the external validation, if you use only 1 field, the AUC is 0.7. However, if you use a kind of risk factors for prediction, the AUC for risk factor in the internal validation was still 0.7. But you combine the deep learning with the risk factor prediction, the AUC improved to be like 0.8. That's from internal validation. The same thing for the external validation using only single field for AI. If you use only risk factors, the AUC was 0.6. But if you combine risk factor and single field AI, it's improved to be like 0.7. Here's the, you can see the picture here. The blue line here is when you use only risk factor. And the red line here is when you use combined risk factor and the AI, deep learning. And here's the A is for internal validation of 3 field, and then B is internal validation with single field, and here's C is external validation with a single field. This picture also show you the plot of the over here. The blue line is positive predictive value, and the red line is for negative predictive value. This is for internal validation 3 field over here, and this is internal validation single field. This is external validation for single field. And this is a kind of survival analysis, the Kaplan-Meier analysis for the incidence of mild-adverse diabetic retinopathy. Here is for the data set of internal validation of the 3 field AI. This is internal validation for single field, and this is external validation for single field. Well, in terms of AMD, let's move to AMD. I think this is another interesting paper published last year, I think. They try to make an AI to make a prediction of detection of pseudodrusen using color fundus photo. Actually, the retinal pseudodrusen was better detected by fundus autofluorescence image on your left-hand side, but not really be able to detect using color fundus photo on your right-hand side. The thing is, when you have reticular pseudodrusen, you have a risk of having wet AMD much faster than you didn't have a reticular pseudodrusen. And this model, they use the data annotation from the ARED Reading Center, where they use data from the fundus autofluorescence and they transfer the label of reticular pseudodrusen positive and negative onto the color fundus images over here. And then they create two models. The first model is to perform prediction on the images of fundus autofluorescence. And the second model is to perform analysis on the color fundus images. But you can see for the validation set, the model for making prediction on fundus autofluorescence have an EUC of 0.94, and the model for making prediction on the color fundus photo, which had a label, which is transfer knowledge from the fundus autofluorescence, have an EUC of 0.83, which is pretty good. When they compare to the retinal specialist, you can see the model for prediction on the color fundus images still have AUC of 0.82. And here the prediction of the retinal specialist is quite down below here. And the AUC from the model that make prediction on the fundus autofluorescence still have like AUC of 0.96. And here below is the prediction or detection from the expert, which is lower than the AI. I think this is another important paper where they make a prediction of conversion from dry AMD or not having dry AMD to be like wet AMD in the future using deep learning. And they do a prediction on the OCT images. Here they use data from patients with an eye of having wet AMD and had injection already. And they use data from the fellow eyes for study. They create two models. The first model perform a prediction on the original OCT images. And the second one is perform prediction on the OCT images that they already do the tissue segmentation of having subnerve fluid or without subnerve fluid or thickness, stuff like that. And they combine these two models into one. And then they make a prediction of having conversion to wet AMD within 6 months. And here below is an example of the fellow eye OCT that have clinical ground truth. You can see this case. Well, it has conversion to be wet AMD within 11 months. Here's the result of this model. They can predict the conversion at 6 months quite accurately with the AUC of 0.77. Well, if you compare to the expert grading, they are lower than the AI. This is a lie for the AI. And if we use other biomarker like drusen volume or even hyperrefractive foci, they are far below of the performance of the AI, which is the blue line here. This is another interesting paper just published by the Singapore group. Well, they would like to create the deep learning system to make analysis on fundus photo to detect myopia, and they use blockchain technology as well. Here, the data set of more than 226,000. They create two models of this study. The first one is to detect myopic macular degeneration, and the second one is to detect high myopia. The internal validation of these models is performed on the datasets from the Singapore, and the external validation is from the dataset from China, Taiwan, India, Russia, and the UK. And they also perform the kind of validation against 6 human experts in a randomly selected dataset of 400 images from the external dataset. And they use blockchain to demonstrate secure data transfer, model transfer, and model testing across the sites in Singapore and China. Here's the result from this study. Where for the external validation, they found well, the AI to have the AUC of more than 0.97 for detecting of myopic macular degeneration, and the AUC of more than 0.91 for high myopia. And when they compare against the 6 retinal experts, deep learning system in this study outperformed all the experts. And they found, well, they can use the blockchain technology quite successfully in this study for data transfer, model transfer, and model testing across the sites between Singapore and China. Here's the schematic drawing of how the model in this study worked. Well, the first step, the first process is do data sharing, and then releasing model, and then sharing model, and then testing model. Here are multiple components of this model. The first one is local FTP server, and they have data encrypted, and they have like blockchain network, and they have data and model metadata and interaction records, model accuracy. And they store all the models and data in the cloud storage from Amazon S3, and they encrypt the model. And they have the blockchain nodes hosted in the primary dataset in Singapore, and at the AI center, and at the external testing centers in Beijing as well. And they propose to use this model, this AI, in 2 settings. The first one, A here, is for primary care unit. Well, you may use this algorithm to detect high myopia first. If you have high myopia positive, you may use the second algorithm to analyze images to find if they have if the patient have myopic macular degeneration or not. If the patient have myopic macular degeneration, they may be referred to retinal specialist for treatment. If they don't have myopic macular degeneration, they may have re-screening every 1 or 2 years. If they don't have any high myopia, they don't need to have any screening unless they have other retinal disease. And the second option for using this model is B here, is to use in the large scale epidemiologic studies to detect myopic macular degeneration and high myopia. Well, there are many new papers published for retinal disease. I think this one is quite interesting as well. They use AI for making diagnosis on inherited retinal disease, which sometimes is quite difficult to make diagnosis. They are doing it. And here's another model they use for detection of multiple fundus disease at the same time based on the color fundus photography. And here's the last one. They used retinal photograph to detect visual impairment for referral, which is quite interesting because, well, it's going to be interesting because you may not use visual acuity, but you only use retinal photography to determine visual impairment. Well, I think there's not need to be a lot of proof in the future. However, well, this is a summary. For DR, I think we are in the phase of deployment, DR detection using AI in the real world. However, deployment in nationwide programs, such as in Thailand, we have more than 4.5 million diabetic patients. It's not easy. We are developing it at the moment. And I think in the post-COVID-19 era, the models for predicting DR progression is very important because it may increase the screening interval for particular patients. For AMD, OCT images still play major roles for AI. The aims are for early detection of wet AMD conversion and monitor treatment of AMD. And there will be more algorithms on detecting other relatively uncommon retinal disease are on the way. I think that's for my presentation. Thank you very much, Ken. Back to you.
Thank you, Paisan. And it's a very detailed topic, very complex. It changes every month, and I always learn something new when I hear you speak, or Tian speak, or Daniel speak. So, I mean, we've got a question from the audience. I think it's something that all of us are thinking about. How accurate is AI for diabetic retinopathy screening? Is it ready to be used for public work now? Is it reliable and more accurate than human graders?
Well, as I mentioned, based on the retrospective study, we have 99 accuracy in majority of the published algorithm. But for real-time and real-world screening, the accuracy may come down a little bit, but not much. It's still like 95% accuracy. But the thing is, well, when we deploy in the real world, you have many problems. Just like you may face a problem of ungradable images, and how do you fit the AI into your current workflow? And the important thing is, well, you may need to have your AI approved by the FDA in your country before you deploy in the real world. So I think, well, we proved that, well, for retrospective study it works, and prospective study it still work, but for real world study we need another proof. And I think for Singapore's data set, for Singapore's algorithm, I think they use in the real world in some country and in Singapore as well. I think Daniel's and Tian's job. Yeah.
I think it's that's definitely AI grading is definitely here to stay, and I'm excited that they're also looking at other retinal diseases apart from DR and AMD.
Right.
Okay, Gus, there's a question from the chat also about use of intravitreal dexamethasone in eyes with posterior capsule rupture. What are your thoughts about that?
Yeah, so this is an area of concern because of the fear of the migration of the implant into the anterior chamber, which is something you don't want. And the number of reported cases, I have seen a couple of cases in my practice where there's migration of the implant to the anterior chamber. So in general, if there is a deficiency in the posterior capsule, it's not recommended to give intravitreal Ozurdex. Yeah, thanks.
Great. Okay. So Dr. Barbara Parolini, are you still there? Oh, she's on.
Sorry.
Hi. Yeah,
I'm
thank
here.
you for staying with us. I was just wondering, what is the status of AI in Italy or Europe at the moment? I mean, is it something that's going to be rolled out in the near future in Europe?
No, well, I have to speak for Italy, not Europe. It's not the common news. It's still something that it's more at a research level, but not in daily life. Okay. It's more at the level of collecting data and hearing talks in the meetings. It's not yet in real life.
Yeah.
There are no screening programs. Also, it's because diabetes is very well controlled. There are no real needs for screening program like that from a distance. So I think it really depends on the reality of each territory, each country. So we know it's going to take place, but not in real life now.
Okay, great. Wonderful. And just going back to the intraoperative OCT with the Provio Leica system, is it commercially available now? And do you know how many have been installed worldwide?
No, worldwide I cannot tell, but it is available. And as I was saying, they're going to change model into an incorp because now it's a separate tool. It's a separate box, and it takes space in the OR. So I, of course, advise to wait a couple of months. It will be available into the microscope in the Proveo. And that's new. So it is available, but it's not widespread. So I don't think there are many samples even worldwide because it's building up right now. And so
I think it's the same argument as the 3D system because it essentially is purchasing a new microscope for your OR.
It's true, but it's because some of us had to commit to do the research and go in and see where the technology goes and if it's really useful or not, and then making it more user-friendly, easy to use, and really understanding what is the purpose, what are the indications, what are the advantages. Then it will help the companies to make it easier, to make it cheaper, and then it will become it will go in every OR. I'm sure about that.
Sure.
Like it happened to the diagnostic OCT, it will be the same.
Yep. Thank you.
Yeah.
Okay, I think Paisan has one last question about blockchain technology and AI.
Yeah.
Do you have any queries, any opinions about that?
Well, blockchain is for data transfer and privacy. So, well, it's quite difficult to, conduct a research and using really, checking on the technology itself. Just like in the study from Dan and Tian, they just use blockchain to demonstrate how it works, but they're not really, make a judgment on the technology.
Yeah.
Just make use of it. Yeah.
Great.
I have a question for Gus. Well, do you think, well, you're going to use the steroid for like treat and extend regimen? Have you explained on that? And you think it's going to work?
Okay, there's no, as far as I know, there's no data on the use of intravitreal dexamethasone in a treat and extend fashion. But I can imagine that we can deploy in using the same basic principles, because the key is whether you can establish the stability. The problem with, as I see it, with the use of dexamethasone is at the moment, majority of the use is under treating, if you see what I mean. Because if you look at the efficacy, the how quickly the edema recurs, most people do not consider retreating shorter than 3 months, right? So I think because of these, actually in our clinical practical use of dexamethasone, we are under treating a lot of our patients. So therefore, if you want to extend this into a treat and extend kind of regimen, the key is that you need to achieve the stability first. So if you're under treating, the likelihood of you achieving stability is lower. So therefore, I don't, so maybe that explains why we don't really see the use of treat and extend regimen in reported.
I see.
But in principle, I don't see any problem with adopting treat and extend as a retreatment strategy for the use of intravitreal dexamethasone.
Yeah, you may start it, and we can cooperate. Well, it's quite interesting.
Great idea. Yeah, definitely.
Yeah.
Okay. Well, we've just run over 3 o'clock. So I'd like to thank our speakers today: Gus Laude from Singapore, Paisan from Bangkok, Barbara Parolini from Brescia, Italy. Thank you so much for your time and effort to present your interesting. We've had a very diverse range: one surgical retina, one medical retina, and one AI talk. It's rare to get all 3 of this in one symposium, but I guess it's useful for our viewers as well to understand what's happening in the retina world at the moment. I'd like to wish you all the best and hope we can meet up in person very, very soon in the near future. Thank you very much.
Thank you.
Bye-bye.
Thank you all.
Bye.
Bye-bye. Take care all.